I'm still using Dr. Benjamin Rush's example to make the same points that I did back in 1984 in The Reign of Error. I imagine that'll make a fairer number of psychiatrists even angrier than it did back then. But I don't do it flippantly or lightly. I really use examples like that because I think the point is a valid one, that professionals at that time believed in what they were doing. I have no reason to doubt that they did. Doctors were respected professionals, and they used the tools they thought they had. But we now can look back and realize that, of course, that it was a circular kind of reasoning. They were creating an alleged condition that didn't exist, so that the treatment, the procedure they were doing to people, and by force in almost every case, what didn't, was only there. The only purpose it had was to rationalize what the doctor was doing. There was no rational basis for it. And that is what psychiatry is still doing. So I don't accuse anybody of malice or ill will or a lack of the kind of things we hope from doctors. But that doesn't mean we have to just accept what is going on. And I think a good way to explore whether or not what I'm saying has any validity is to follow it up a little further. Let's move on to some treatments that still are going on to this day. And what I want to do is I want to talk about electric shock treatment, because while that was becoming rather unpopular when I was in my training and in my early career in the 70s, has, along with the rest of psychiatry's medicalized image, made quite a comeback in terms of acceptance by the medical community, by society, and so forth. And I maintain that the basic flaws are, in essence, the same as what was happening in Dr. Rush's era. Electroshock treatment is still done, and it involves giving enough electrical current to the brain to change the symptom pattern of the patient. Traditionally, this would be done for people who were depressed. Not just mildly depressed or moderately depressed, but people who were depressed enough that those around them felt they had reached a point where they needed to do something beyond what they were already doing. And for quite a long time, medications were being used as the first line of treatment, along with some kind of hospitalization and so forth. And shock treatment were originated back in the 1930s with various kinds of chemicals and then electricity. They were all rationalized in ways which some are now considered absurd. Like some people in the beginning said, we don't think that schizophrenics and depressives, they seem to have different courses, so shock treatment can be good for people who are depressed, and some people said they were good for schizophrenia, so you had different fads and so forth. But in today's world, people don't say that anymore. They try to claim that we don't know how it works, but somehow it changes the brain in a way which improves the patient. The fact is that the only evidence that has ever been generated is that it does change people for a while. And then the question is, well, is that change an improvement? And there, it's not so clear. If you ask people who've received the treatment, you will find people of different, they will make different kinds of statements. But the point that I find that makes shock treatment so unacceptable is that it's not at all unclear how it works. It's very clear how it works, because anybody with medical training should be able to see that it works by damaging the brain. Electricity to the brain cannot do anything but damage, because you're putting amount of energy that is way beyond anything that the brain is designed to. The electrical, so-called electrical things that happen in the brain are not electrical. They're movement of ions, sodium and potassium and so forth, in and out of cells. And electricity is like a vast insult to the brain that is just not in the realm of the way the brain could possibly work. So what you're doing to somebody is causing a new condition that is what we would call an acute brain injury. Any neurologist or medical doctor would tell you that if you get in an automobile accident, if you get assaulted, if you have some kind of metabolic disease that affects the metabolic environment of the brain can react to the trauma, if it's a drop in sugar, etc. And the trauma will show itself in symptomatology, confusion, memory impairments, and so forth. Now, the key thing to understand is that what happens in psychiatry and the people surrounding the patient is there can be such a sense of desperation of trying to change the person that anything different than what the person has been like gets defined as an improvement. If they were crying, refusing to eat, having suicidal thoughts, etc., if you can break up that pattern, it gives everybody surrounding the person a temporary sense that I've done something. We've changed the course of the depression. So the person may not be talking about suicide for a while. They may start eating better than they were. They may tell you things that they may say that I'm better. And if you want to broaden your definition of improvement to mean anything other than the way they were, you can do that, but the real test is, do people stay better enough to justify the damage that you were doing to them? And to me, the answer is clear that you're not. There is no good evidence that people stay better long enough. What happens is people go back for more of it. Then they go back for more of it later. And in the meantime, they are losing some of the part of what makes them human. They're being taken to a lower level of capacity because some of their intellect will suffer, some of their memory will suffer. I remember, I'm not really trying to rely on anecdotes very much in this blog, but I will tell you about a patient who told me once she met up again after many years with a man who she remembered that she had known him, but she really didn't remember much else. And she told me that after she was being reacquainted with this man after after maybe 20 years, she realized, because of what he was saying and telling her, he had been a former lover of hers. And she didn't remember that. And her depression came flooding back because of the humiliation that she was less of a human being now, that she didn't even have her own memories of that part of her life. And that's the kind of thing that can get lost to the psychiatrist, because that psychiatrist maybe who gave that shock treatment was long gone. The family members or friends who supported her, or who kind of encouraged this to be done, to them it might have been a relief. But the point I'm really getting to is that nobody should have ever made the decision that that should be done except her. She had been forced to get that treatment. And that was something she would never get over. And I was seeing her because she knew through the grapevine that Dr. Coleman doesn't ever do forced treatment. That puts me in a very small minority amongst the psychiatric community. It's a very difficult issue, but it's a path that I chose, and I haven't been actively treating patients for a number of years, so it's no longer an active issue, but It's not easy to be practicing in a society where there are expectations that you will put people in a situation where they no longer have control of whether they get a treatment. But I can tell you that part of my calculus was the arguments that they made for using shock treatment, and still to this day, one of the biggest ones is, you know, if you don't do that, you're abandoning patients. You are contributing to the risk of suicide. Patients will die if you don't give them shock treatment. And what I say back is, you don't have the evidence to show that more patients will die because you don't force this treatment on them than will die because you do force the treatment on them. And what I say is, more patients will die and more patients will be hurt, and society will be hurt because of how people react to having things done to them that they do not choose to have done to them. That in fact what you're doing is you are raping them, you are assaulting them, and that people will kill themselves in order to avoid having you do it to them again. But it will never be recorded as a suicide caused by something that you already had done to them in the past. But if as a society we want to be mature enough to really face into these questions, you have to at least entertain that possibility. And I am somebody in the profession who has decided that more people will die because of what we do to them against their will than will die because of what we refuse to do to them. So it's not simple. And I understand that people have disagreements. I ask you to think about it and don't allow yourself to be bludgeoned into agreement because of political statements, alleged patient support groups which support the pharmaceutical industry and are paid by the pharmaceutical industry. Certainly the psychiatric community has not exactly brushed themselves with honor in terms of the way they have conducted things in the last 50 years. So the lesson of electric shock treatment, to put it back in perspective, is to say that when Benjamin Resch was bleeding people and we don't do that anymore, we didn't leave the arena of doctors deciding for people what was good for them and rationalizing things which clearly, to me at least, are not good for them. And where that's going to take us next is the really big one, and that is the subject of labeling people with so-called mental diseases, which then rationalizes the use of psychiatric drugs.